Thank you to ISWOG and the course organisers for the invitation, and it's an absolute pleasure to speak today about point-of-care ultrasound for symptomatic pregnant women in the first trimester. I have no conflicts of interest to declare. Point-of-care ultrasound is really use of bedside ultrasound performed by a healthcare provider. This is really quite a broad definition. What is its potential for use in early pregnancy, and what problems might it help us to solve? Firstly, to answer that question, we really need to understand the scope of the problems in early pregnancy. And we must remember that complications in early pregnancy do contribute to maternal morbidity and mortality worldwide. In lower resource settings, it is thought that mortality from ectopic pregnancy, for example, is up to 4%, with women often presenting quite late in the disease process and moribund. Ectopic pregnancy remains an issue in higher resource settings, and in fact, the latest Embrace report suggested that there was more deaths, and deaths have risen as a result of ectopic pregnancy in more recent years. And yet we often only consider ectopic pregnancy, but miscarriage is the commonest early pregnancy complication, with potential for risks from complications of miscarriage, such as hemorrhage and sepsis. But these are very, very little reported in the literature. But given that the latest Lancet series estimated that there are 23 million miscarriages worldwide per year, there must be a huge amount of pathology as a result of pregnancy loss. And therefore, we must acknowledge that this might be associated with significant morbidity and mortality worldwide. Therefore, there's a clear need to improve access to appropriate care for women in early pregnancy and diagnostics. And could point-of-care ultrasound play a role in this? Well, the role of point-of-care ultrasound in early pregnancy could help in the rapid assessment of pregnancy status, evaluation for potential complications, and also it might allow for quite quick decision-making in the acute setting. The impact of this could be on triage and possibly optimizing referral pathways and optimizing use of clinical resources. And this is really clearly important in both a low and a high resource setting. Symptoms in early pregnancy are common, with up to 20% of women presenting with pelvic pain and or vaginal bleeding. And really, in the main aim of point-of-care ultrasound in those with symptoms is to assess for possible ectopic pregnancy and possible complications from pregnancy loss. How best are these ultrasound scans performed? Well, transvaginal ultrasound really remains the gold standard in early pregnancy imaging due to optimal views of the female pelvis. In addition, most guidance and data on miscarriage diagnosis, as an example, are based on transvaginal ultrasound imaging. However, transvaginal ultrasound could be used really in point-of-care setting, but most of the time when we consider point-of-care setting ultrasound in early pregnancy, we're thinking about using a transabdominal scanning approach. This can allow for us to obtain really key views of pregnancy. And the best way to do that is to learn to optimize our imaging, ensuring optimal patient positioning and allowing us to use the equipment that we do have in the best possible way and considering bladder filling for transabdominal imaging. However, large ultrasounds are very costly. And there are many other considerations for their use in the point-of-care setting, such as maintenance, cleaning of equipment, training. And in addition, we mustn't forget that up to 13% of the world do not have access to electricity. Therefore, handheld devices may provide a solution, with some even offering a transvaginal probe alongside the handheld device, which is really ideal for early pregnancy scanning. But we have to think about as well with the transvaginal approach, other considerations such as probe cleaning and disinfection. In fact, handheld devices have been shown to be of use in various systematic reviews of the literature and can change patient management and potentially improve care. So although these studies don't include gynecological cases per se, there is clearly a possibility for use of handheld devices, particularly in a lower resource setting. I wanted to now show some images in early pregnancy to see what we can see with a point-of-care ultrasound approach. And these are some images that we took in our own center using a handheld device, looking at comparing transabdominal imaging and transvaginal imaging. And you can see that on the right here, the transabdominal imaging is very reliable at demonstrating an intrauterine pregnancy with a gestation sag. And this is the same image as a transvaginal scan. In addition, you can see that the measurements are very similar, and we can see that on the right that we can measure the mean sac diameter quite accurately on transabdominal imaging. And in fact, we can also see measure the crown rump length and see a fetal pole and assess for viability with a heartbeat. And we can see that here in this image, where we can clearly see the intrauterine pregnancy that we then zoom down on, and we can see that in fact a yolk sac and this embryo and this early CRL. And if this patient came to us with bleeding and pain, we'd be very confident in triaging the patient and sending them on their way, whether that be in a high or low resource setting. This is, again, a pregnancy of unknown viability, which then was diagnosed with a subsequent miscarriage. And we can see again that the images, and we can see the very small possible CRL. However, there is a caveat to this here, because really most of the studies validating algorithms to diagnose miscarriage and measurements are based on transvaginal imaging. So we're unclear as yet as to the potential accuracy of this modality. However, we could possibly diagnose complete miscarriage, or in fact see women with retained pregnancy tissue using point-of-care devices. Again, we must remember, in women who present to us with pelvic pain and vaginal bleeding, who have heavy bleeding and then a negative pregnancy test and an ultrasound image on abdominal imaging as of the right, showing the uterus with a very thin endometrial stripe, this is likely to be a complete miscarriage. However, this is only in the context of those with a negative pregnancy test. In those with a positive pregnancy test and bleeding and pain and images like that, one might consider a pregnancy of unknown location and would then be obliged to perform serum beta-HCG and progesterone testing. But again, a scan like that might then allow you to triage the patient for onward clinical care, be it through an early pregnancy service in a high resource setting or to a tertiary center in a hospital in a lower resource setting. In the case of ectopic pregnancy, this is what one might see on a transvaginal imaging. And one might see an empty uterus with no pregnancy, and you can see the ectopic pregnancy mass here. Transabdominal imaging, again, one might just see the empty uterus and not visualize directly the ectopic. But one would treat the patient in front of them, taking the whole clinical picture, including risk factors and symptoms and clinical presentation. And again, this might therefore allow for subsequent triage of patients. We can, of course, assess for hemoperitoneum on transabdominal imaging, and this can be very, very reliable. And here you can see that when we see on transvaginal imaging hemoperitoneum above the uterine fundus, this can signify quite significant hemoperitoneum. When we look here just below through a fast scan at Morrison's pouch in the hepatorenal space, if you see fluid and blood here, we've already got a blood loss of over 500 mils. So again, this can really help us. Point-of-care ultrasound in the emergency setting can help us triage patients optimally, particularly in the context of ectopics and ruptured ectopics. So is point-of-care ultrasound reliable in early pregnancy? And you can see here, this is data published in our unit at Imperial College on 101 patients. And in fact, it shows really good correlation in measurement and final diagnosis. Although this is a small study, you can clearly see the potential for utility of point-of-care ultrasound in early pregnancy. And what are the potential advantages? Well, I've suggested a few: that it would provide us with immediate results at the bedside. It could improve the patient experience and satisfaction and reduce the anxiety of waiting. It might reduce the need for referrals and, of course, waiting times, particularly in emergency settings. One could question whether this might be more cost effective. And as always, as I have alluded to, this is particularly useful as a triage tool in any clinical setting. This is a very useful study demonstrating that although ultrasound has a potentially low uptake, when it is used, it is a very good triage tool for ectopic pregnancy. And so again, there is good data and real-world data out there to demonstrate that point-of-care ultrasound could and reliably triage women with ectopic pregnancy. In addition, this systematic review has also shown that although uptake of point-of-care ultrasound and ultrasound in general is quite low, and in general, sadly, presentation for things like ectopic pregnancy is quite late, it showed that where ultrasound was performed, you were more likely to present with an ectopic pregnancy that was not ruptured. And therefore, again, this suggests that ultrasound could potentially reduce harm and allow for earlier intervention and lower morbidity in this context, which is very, very promising data. In other clinical settings, more high-resource settings, we can see that point-of-care ultrasound has been shown to improve efficiency and reduce waiting times and length of stay in the emergency room by, for example, showing an intrauterine pregnancy so women can be sent home, or potentially even impact treatment. And a study by Stone et al. Showed that it could triage those with ruptured ectopic pregnancy and reduce the time to the operating theatre. So instigate appropriate and immediate emergency care. And therefore, these are examples of how we can allocate resources to those most at need. There is very good data that shows that this is also acceptable to women. And this is clearly really, really important. But what might be the limitations? I think we've shown here the potential uses of point-of-care ultrasound. I've shown to you the data that suggests its utility, but we must also recognize its limitations. It's important to know that there's still operator dependency, and there remains a need to train people to use ultrasound, whether it be transabdominal or transvaginal or handheld devices. And we also have to think about that most in early pregnancy care, our gold standard is transvaginal imaging, and this can be really challenging in a point-of-care setting. And we're more reliant on transabdominal imaging. And we have to think about the transvaginal scans with issues such as probe cleaning, access, and appropriate training. With transabdominal point-of-care ultrasound, we've got to be cautious as well, because there is potential for misinterpretation and misdiagnosis, particularly where we don't see a pregnancy within the uterus in the context of a pregnancy of unknown location or ectopic pregnancy. We have to remember that there is a risk, therefore, of doing a number of negative laparoscopies if that is our sole diagnostic tool. And in the same vein, we could potentially misdiagnose miscarriage, which would be terrible consequence for the family. And therefore, it's really important, in my belief, that point-of-care ultrasound in early pregnancy is really more of a triage, moving, and then where identifying a problem, then referring on as appropriate. But this therefore means that we really need a robust onward referral pathway that is really accessible. So meaning access to transvaginal imaging, blood tests, and of course surgery and expert care and counselling. And this has to be considered. There is really no point in setting up ultrasounds in a low resource setting, but where a problem is identified, there is nowhere else for patients to go. So it's really important to think about the entirety of that pathway. We must also consider potential barriers to ultrasound in all clinical settings, but particularly low resource settings. And we discussed the potential role of handheld ultrasound to overcome some of the challenges in relation to equipment and environment. But we also have to consider who does these scans in which clinical setting. And we have to think about the concept of task shifting and training skilled attendants as an option to allow women the access that they need to high quality, appropriate, triage-based point-of-care ultrasound. And in particular, we've also got to think of the protocols and guidelines, and particularly, again, as I've mentioned, in diagnosis of miscarriage. It may be possible to diagnose miscarriage on transabdominal ultrasound, but we really need to think about the cutoff values we're using and how these might change on transabdominal imaging. And therefore, we need to do some more work and studies to understand that. So what are the conclusions here? Well, I think we have to conclude by saying that transvaginal ultrasound assessment of early pregnancy complications really remains the gold standard here. We might need to adapt the diagnostic criteria for specific diagnoses, such as miscarriage diagnoses, but we really need more research work to understand what those cutoff values might be. We have to consider the potential advantage of technology such as handheld probes, some of which are transvaginal. We've got to think about the needs for training that needs to be standardized and integrate point-of-care ultrasound into training programs so people know when appropriate to use it and how to interpret the images and and how then to refer and who then to discharge. And we really need larger prospective studies within the field of gynecology and early pregnancy to really validate when and how to use point-of-care ultrasound in this context. Thank you so much for your time. Thank you for listening, and I look forward to taking your questions later.